Hello people, welcome back to Pharmacy Medicine. Do you feel like you're constantly running to the bathroom, waking up at night just to pee, or suddenly needing to go but not making it in time? You might be dealing with something millions silently suffering from, that is overactive bladder or OAB. And let me be clear, it's not just a normal part of aging. Overactive bladder is very common urinary condition that affects 1 in every 6 people. That's over 33 million Americans and millions worldwide. In a healthy bladder, the muscle called the detrusor waits until it's full before contracting. But in the overactive bladder, these muscles squeezes too early even when there is hardly any urine inside. And this leads to the classic symptoms of urgency, that means a sudden intense urge to urinate, and frequency being more than 8 times a day, and nocturia, waking up 2 or more times at night to urinate, and sometimes urge incontinence, not making it in time. About 1 in 3 patients of overactive bladder experiences leakage called OAB wet, while the other 2/3 don't leak but still suffer from the constant urges, OAB, that's called OAB dry. In simple terms, urinary urgency is a sudden feeling of needing to urinate. This is primary symptoms of OAB. It can occur with or without incontinence and is usually accompanied by the urinary frequency and nocturia. And urinary incontinence is involuntary leakage of the urine. There are different forms of urinary incontinence which will be discussed later in this video, but it's more than just a bladder issue. Overactive bladder affects more than your bathroom habit. It can lead to falls and injuries, skin breakdown and infections, UTIs, depression, and even sexual dysfunction. The emotional impact is huge, from the low self-esteem and intimacy problems to the social isolation and the sleep issues. People skip drinks to avoid the accidents, limiting their hydration and risking the dehydration. And let's not forget the financial hit. Adult diapers and the pads aren't cheap. If you struggle with these symptoms, don't ignore them. Overactive bladder is treatable. Talk to your doctor. Don't suffer in silence. Take back control of your bladder and your life. Before we move on, it's important to understand that the different types of urinary incontinence, which is nothing but the involuntary leakage of an urine. First one is urge incontinence, a sudden and unstoppable urge to urinate, which means patient cannot hold in urine long enough to reach the toilet and is associated with the neuropathy found in those who have diabetes, stroke, dementia, Parkinson's disease, or multiple sclerosis, although people without comorbidities are affected also. And the second form of incontinence is stress incontinence. Urine leaks out during any form of exertion like exercise, coughing, sneezing, or laughing as a result of the pressure on the bladder. And the third form of urinary incontinence is mixed one. It's a combination of urge and the stress incontinence. Coming to the next one, it's a functional incontinence. There is no abnormality in the bladder, but the patient may be cognitively, socially, or physically impaired, thus hindering the access to the toilet. Example, patients in the wheelchairs. And the last form of incontinence is overflow, which means the leakage that occurs when the quantity of the urine stored in the bladder exceeds its capacity, often occurring without the urge to urinate. BPH is the most common cause, which is nothing but benign prostatic hyperplasia. If you are struggling with a frequent urination at the night, it might not be just overactive bladder. Check out our video on the BPH, benign prostatic hyperplasia, right here on the channel to find out more, including causes, symptoms, and treatment. So far, we have seen the symptoms like urinary urgency, urinary frequency, urinary incontinence, nocturia. Now let's see the pathophysiology and etiology of overactive bladder. The bladder is commonly referred to as balloon with an outer muscular layer known as an detrusor muscle. The detrusor muscle and the bladder outlet functions are neurologically coordinated to store and expel the urine. The detrusor muscle is innervated mainly by parasympathetic nervous system, which means acetylcholine acting on the muscarinic receptors, while the bladder neck is innervated by the sympathetic nervous system. The internal sphincter is innervated by the sympathetic nervous system, and the external sphincter is innervated by the somatic nervous system. Both voluntary and involuntary contractions of these detrusor muscles are mediated by acetylcholine activation of muscarinic receptors, that is M3 or M2 receptors. If the receptors like M3 might sound technical, but once you get them, overactive bladder makes total sense. So don't miss our research or explain video. It's made simple, visual, and easy to understand. Coming back to pathophysiology and etiology, in the overactive bladder, there is an inappropriate stimulation of muscarinic receptors on the detrusor muscle, causing involuntary contractions and the feeling of urinary urgency. This is a contraction of a bladder even when it is not full. Of the 5 known muscarinic receptors subtypes, the human bladder is comprised of M2 and M3 receptors in 3:1 ratio. It is the M3 receptor that is responsible for both emptying the contractions as well as the involuntary bladder contractions of incontinence. In the overactive bladder, the detrusor muscle is hyperactive. That means overactive, causing the symptoms of frequency micturition, urinary urgency, nocturia, and incontinence. Now let's see what are the risk factors for the overactive bladder. The age greater than 40 years, diabetics, prior vaginal delivery, obesity, and neurological conditions like Parkinson's disease, stroke, dementia, and the drugs that increases the incontinence like alcohol, cholinesterase inhibitors, diuretics, sedatives. And also due to restricted mobility, hysterectomy, or pelvic floor injuries are the risk factors for this overactive bladder. Have you checked the few of those boxes? You're not alone, and we are here to help you. Tap that like button, share with someone who needs to hear it, and subscribe so you never miss the another episode. Now let's see the diagnosis. Diagnosis require a careful patient history intake including comorbid conditions, duration of the symptoms, baseline symptoms, fluid intake, and type of fluids with or without caffeine. A physical examination and the urine analysis, validated questions such as urinary distress inventory, that is UDI, or overactive bladder questionnaire OABQ, are used to quantify symptoms. Patients may be required to complete a bladder diary to accurately measure the intake and the voiding information. A urine culture and the post-voidal residual assessment may be performed to rule out the other causes. If you have made it this far, you're serious about fixing this, and that's awesome. Make sure you smash that subscribe button so you'll stay in loop as we break down the treatment options coming up next. Now let's move on to the treatment. Overactive bladder can either be treated with a non-drug treatment or with a treatment with the drugs. Behavioral therapies are considered first line to improve the overactive bladder symptoms. These includes bladder training, delayed or scheduled voiding, pelvic floor exercises, that is kegel exercise, urge control techniques with distract self-assertion, fluid management, dietary changes, avoiding the bladder irritants such as caffeine, weight loss, and the other lifestyle measures like stopping the medication that can worsen the overactive bladder, or with the diuretics changing the time of the administration to avoid the nocturia. Behavioral therapies can be combined with other treatment modalities such as medication. The surgical intervention should be reserved for the rare non-neurogenic patients who has failed all other therapeutic options and whose symptoms are intolerable. Proper technique of the Kegel exercise is the key. Instruct the patient to imagine that they are trying to stop urination. Squeeze the muscles they would use if they sense a pulling. Those are the correct muscles of the pelvic floor exercise. Pull in the pelvic muscles and the hold for a count of 3, then relax for the count of 3. Patient should work up to the 3 sets of 10 exercises per day to reduce the wetting episodes. Let's move on to the drug treatment. A stepwise approach is recommended that begins conservatively with the behavioral therapy as we saw before, and the treatment depends upon the degree of severity felt by the patient. With the severe symptoms, treatment can begin at the higher levels. The drugs are added to the behavioral recommendations like Kegel exercises, bladder training, weight loss when needed. So let's see the treatment options for urge incontinence and mixed incontinence. Mixed incontinence has an urge incontinence component and is treated in similar manner. The first line drugs include anticholinergics like oxybutynin or beta-3 receptor agonists like mirabegron and onabotulinum toxin A, that is Botox, has higher efficacy, but it's not a first line due to the cost and the route of administration through the urethra and into the detrusor muscle. Nerve stimulation or surgical intervention is used last. Women with the post-menopausal symptoms of vulvar and vaginal atrophy can use vaginal estrogen in a cream or a ring, which may provide a modest relief of the symptoms. But estrogen is not an FDA approved for this purpose. To summarize, first one is behavioral therapy with anticholinergic medications or beta-3 agonist is used. If there is no response, then the next step is to go to the Botox injection. And if there is no response with the Botox injection, nerve stimulation or the surgical treatment is preferred. Now let's see the stress incontinence. The medication used for the stress incontinence are not FDA approved for this use and have minimal efficacy. But there is a lack of more effective options. Pseudoephedrine, an agonist of norepinephrine and epinephrine, causes the adrenal types effects including tachycardia, palpitations, nervousness, anxiety, headache, and insomnia. Duloxetine is commonly chosen when it is possible to treat two conditions with one drug. Example, incontinence with depression. Though it has a little efficacy for incontinence. Now, let's see the drugs. Anticholinergic drugs, or also known as antimuscarinic drugs, competitively bind to the muscarinic receptors and block the acetylcholine from binding. This limits the contractions of the detrusor muscle. Extended release formulations are preferred over immediate release formulations due to lower risk of dry mouth. The drugs that are more selective for M3 receptors like solifenacin, tarifenacin, and fesoterodone has few CNS side effects than the older non-selective drugs such as oxybutynin. The Beers criteria recommend avoiding anticholinergics in patients aged 65 and older due to the risk of delirium and cognitive impairments. So the drugs include oxybutynin, available as tablets, topical gel, and patches. The tablet form, they are available in immediate release and extended release as well. The dose of the immediate release is 5 milligram per oral 4 times a day, and the patch is apply one patch, that is 3.9 milligram per day twice weekly for every 3 to 4 days. To the topical gel, apply contents of one sachet or a one pump daily. Coming to the next drug, that is tolteridone, which also available in immediate release and extended release. The tolteridone is given 1 to 2 milligram per oral twice a day, or tolteridone extended release in 2 to 4 milligram per oral daily. Coming to the next drug is trospium, which is also available in immediate and extended release. The trospium is 20 milligram per oral BD or 60 milligram per oral daily for the extended release tablets. And this trospium should be taken on the empty stomach. Coming to the next one, that is solifenacin. This branded as an Vesicare is given 5 to 10 milligram per oral daily, and the darifenacin is given at 7.5 to 15 milligram daily, and the fesoterodone is 4 to 8 milligram per oral daily. Coming to the safety, side effects, and monitoring parameters, contraindications include uncontrolled narrow angle glaucoma and urinary retention, gastric retention, and decreased motility. Warnings and the monitoring parameters include agitation, confusion, drowsiness, dizziness, blurred vision, hallucinations, and headache, which may impair physical or mental abilities. Use caution if performing the tasks which require the mental alertness, example, operating the machinery or driving. Angioedema of the face, lips, tongues, and or larynx. The side effects of this anticholinergics include dizziness and drowsiness, more greater with the oxybutynin and less with the newer selective drugs like solifenacin and darifenacin. Xerostomia, which means a dry mouth, constipation, dry eyes, blurred vision, urinary retention, and application site reactions for the topical gel or a patches. Key points include decrease the dose in renal impairment, that is creatinine clearance less than 30 ml per minute with fesoterodone, solifenacin, tolteridone, and trospium, but do not use trospium extended release in the renal impairment. The key note here is Ditropan XL, which is oxybutynin release, is an OROS formulation and can leave a ghost shell, that is empty shell. And the quick quiz question here is, what is the drug that is used in the BPH also leave the empty shell in the stool? If you are more quick, go through the video on this channel on the BPH and comment the answer below. Oxybutynin patch and a gel causes less dry mouth and constipation than the oral forms. And also here, let's see what are the side effects of anticholinergic drugs. Mainly causes the side effects on the peripheral and central parts of the body. And the peripheral side effects include dry mouth, dry eyes, urinary retention, constipation, and tachycardia. The central side effects like sedation, dizziness, and cognitive impairment. Now let's see how to decrease the risk of dry mouth. Dry mouth is a major reason that a patient fail to comply with the anticholinergic treatment. Choosing a drug that minimizes a dry mouth can improve the adherence. Try extended release formulations which are lower risk than the IR formulation, or try oxybutynin gel or a patch, or beta 3 agonists have the lower incidence of dry mouth and can be helpful in patients who cannot tolerate the anticholinergic drugs. Try non-drug options to help with the symptoms. Avoid mouthwashes with the alcohol. Use ice chips, water, sugar-free candy, or a gum. The main drug interaction for the anticholinergics are acetylcholinesterase inhibitors used for the dementia like donepezil increases the acetylcholine in the CNS. Although overactive bladders drugs primarily stay in the peripheral, that means outside the CNS, some patients can experience CNS side effects like memory impairment. While this is not a drug interaction, use of the anticholinergic drugs can worsen the dementia symptoms. So, risk versus benefit must be considered. Coming to the next class of drugs, that is beta 3 agonists. Beta 3 agonists relax the detrusor muscle and increases the bladder capacity by activating beta 3 receptors. Mirabegron and Vebegron has similar efficacy to the anticholinergic drugs, but they cause the less dry mouth. They can be used in combination with anticholinergic drugs as or monotherapy. The dosing of this Mirabegron is 25 to 50 milligram per oral daily, and if the creatinine clearance is 15 to 29 ml per minute, 25 milligram daily should be recommended, and if the creatinine clearance is less than 50 ml, it's not recommended. And the dose of Vibegron is 75 milligram per oral daily, and the main key takeaways here is efficacy seen within the 8 weeks, and also Mirabegron increases the blood pressure, angioedema of the face, lips, tongue, and or larynx, and the side effects include nasopharyngitis, headache, constipation, diarrhea, dizziness, and more prone to the UTI. And the next treatment option is Ona-botulinum toxina. Will be referring as an Botox is a third line treatment for the patients who are refractory to the first and second line treatment options. It affects the detrusor activity by inhibiting the release of acetylcholine. And the dose is 100 units total dose administered as 0.5 ml, that is 5 units injection across the 20 sites given intradetrusor. Repeat no sooner than the 12 weeks from the previous administration. In the adults treated with the Botox for more than one indication, do not exceed the total dose of 360 units in a 3-month interval. The main boxed warnings include all botulinum toxin products may spread from the area of injection to produce the symptoms consistent with the botulinum toxin effects, like swallowing and breathing difficulties can be life-threatening, and this is contraindicated in urinary tract infections, urinary retentions, dysuria. The keynotes here is prophylactic antimicrobial therapy excluding the aminoglycosides should be administered 1 to 3 days prior on the day and for 1 to 3 days following the Botox administration. And if the aminoglycosides and the drugs affecting neuromuscular transmission can increases the side effects of Botox. Now let's see the treatment for nocturia, that means nighttime urination. The only medication FDA approved for the treatment of nocturia in the adults is desmopressin, an antidiuretic hormone analog that temporarily decreases the urine production. It is administered before the bed to prevent the patients from having to urinate going during the night time. The dose is 0.2 to 0.6 milligram at bedtime. And the main side effects or warnings include severe life-threatening hyponatremia, and this is contraindicated in the patients with the increased risk of severe hyponatremia. Example, excessive fluid intake, illness or the drug that can causes the fluid or electrolyte imbalance, including a chronic kidney disease and loop diuretics or inhaled glucocorticoids, and the patient with the increased risk of fluid retention like uncontrolled hypertension and heart failure. The main side effects is hyponatremia, headache, hypertension, and xerostomia. And the key counseling points for the anticholinergics is it causes the dry mouth, constipation, dizziness. Avoid the mouthwashes with the alcohol and use ice chips or ice cube, sugar, free candies or gum to help with the dry mouth symptoms. And other counseling point is oxybutynin prolonged release less than a ghost tablet in the stool, and the desmopressin causes the low sodium. And that wraps up everything you need to know about the overactive bladder, from symptoms and causes to diagnosis and treatment options. If this helped you, please give it a like, share it with someone who needs it, and don't forget to subscribe for more easy to understand health breakdowns. If you want to know how overactive bladder compares to the benign prostatic hyperplasia, they share the symptoms, but the cause and the treatments are very different. So for that, tap the link on the screen or in the description below to watch our full BPH video next. Stay healthy, stay cheesy with Pharmacy Made Easy. Follow for more.